And welcome to the Health Channel, all health all the time. I'm Laura DeAngelis, coming to you from the Baptist Health South Florida studios in Coral Gables. As many as 75% of women will develop uterine fibroids in their lifetime. That's according to the Mayo Clinic. And while these firm, compact tumors are most often benign, their pain and inconvenience can really take a toll on daily life. Well, with us today to talk about treatment is Dr. James Beninati. He is the director of the Non-Invasive Vascular Laboratory at the Miami Cardiac and Vascular Institute. And we're also joined by Dr. Adam Geronimus. He is the associate director of the Fibroid Center at South Miami Hospital, and both are interventional radiologists with Baptist Health South Florida. Doctors, thank you both for joining us today.
Hello, it's a pleasure to be here. Thank you very much.
Yes, thank you, and we're both very happy to be here with you.
Okay, great. Well, let's kind of start out here by please explaining to our viewers exactly what is a uterine fibroid.
So a fibroid is a benign tumor, a non-cancerous tumor that grows in the muscle of the uterus. And these tumors grow in various sizes, and they can be in different parts of the uterus, and they cause symptoms depending on where in the uterus they are.
Okay, now doctors, with this topic, what you just mentioned, some people at home might be kind of wondering, well, why aren't we speaking with a gynecologist today? So Dr. Geronimus, explain to us, what is your role in treating uterine fibroids?
Our role in treating uterine fibroids comes from the vascular standpoint. As interventional radiologists, we're vascular specialists, and back in 1995, we got into women's health with uterine fibroid embolization, and my partner Jim Beninati here was one of the first to do it in the United States in 1997. And we're really patient care advocates, and we really help guide the women through what treatment is best for them and how we can help out and help their lifestyle with uterine fibroid embolization.
Okay, well, it's great to know that you're both there, and we actually have a video that's also going to offer a little quick look, telling us a little bit more about fibroids. So let's take a look.
They cause a lot of symptoms. They cause women to have heavy menstrual periods and anemia, and they can grow quite large so that they press on a woman's bowel or bladder or give her complaints related to the size of the fibroid. The symptoms of fibroids are heavy menstrual bleeding is the most common one and often causing anemia, but then they can also make women look pregnant when they're not. They can make difficulty with bowel or bladder function, and sometimes they can interfere with getting pregnant or carrying a pregnancy safely to delivery. Sometimes fibroids are easily felt on a pelvic exam, but based on their size and their location, they can be quite hidden. So if you're having menstrual periods that are long or heavy, or having new changes in your bowel or your bladder, or difficulty getting pregnant, it's always a reasonable question to say, could this be uterine fibroids?
Okay, so we just heard about some of the symptoms there in that video, but now let's also talk about who actually gets fibroids, who might be suffering from them, and also curious if age actually plays a factor.
Age absolutely plays a factor, and of course women get uterine fibroids, and the incidence of uterine fibroids increases with age. 20% of women in their 20s get uterine fibroids, and that incidence increases to approximately 40% of women in their 40s. There is some genetic predisposition, even though we haven't localized the exact gene, and hence there are familial tendencies. African American women are much higher risk, but the exact cause of uterine fibroids right now is unknown.
Okay, unknown. Now, I'm also curious, why does it seem that fibroid occurrence and symptoms seem to get worse as women approach menopause?
Well, hormones generally decrease in the perimenopausal period, but in an abnormal fashion. The perimenopausal estrogen levels can be quite different, and there is what's called a perimenopausal estrogen surge in some women, and that could actually cause the symptoms to get worse before they get better.
Okay. Dr. Beninati, let me ask, your colleague just mentioned, there's not really a specific pinpoint, if you will, or a cause to why fibroids happen in the first place. So are there theories about this?
Well, we know, as we mentioned, that there are genetic predispositions. People have looked into multiple other issues, including diet, other genetic factors, but there's no real evidence that we can localize to any one specific factor. And we also know that the symptoms that women get may vary, even though their fibroids may be similar to someone else's. So out there in the audience, you may say, well, I've been told I have fibroids and I don't have symptoms. And somebody else may have similar type fibroids and have a lot worse symptoms. And just little changes in the location in the uterus can cause those changes in symptoms.
Okay, and doctors, we actually have a list here of some of the symptoms that do occur when talking about uterine fibroids. So could you maybe walk us through some of these and again what you might hear from some of the patients that you actually have dealt with?
Sure. Between Jim and myself, we've seen a bunch of different patients, and there's a bunch of different symptoms that occur. One of the most common is what we call metrorrhagia, in which is heavy menstrual bleeding. That could be large blood clots. It could cause anemia if severe. And so the bleeding is one of the biggest symptoms, but then there's also the bulk symptoms, which is pain or pressure in the pelvis, which can cause frequent urination or constipation. You could have pain or bleeding after intercourse. Fibroids can lead to infertility or miscarriage. You can have an abnormally enlarged abdomen. Some of these women actually look like they're pregnant. As a matter of fact, during the physical examination, we talk about weeks gestation in the abdomen size when we palpate and feel how high we could feel the uterus in relation to the umbilicus or the belly button. Also, bladder pressure could lead to a constant urge to urinate and even urge incontinence in some patients.
And one very important thing to remember is that the fibroids are present for a long time, so the symptoms develop gradually. And what a lot of women don't really realize is that their quality of life changes, and they're not even aware of how impaired they are because it happens over a long period of time. So when we're done with treatments, many women come back and they say they feel much better about many facets of their life, not just the bleeding, not just painful intercourse, but all types of things. And what has happened is they don't realize that over years and years they've had this slow decline in their function. So once we treat them, there's usually a huge change in quality of life.
And we frequently talk with the patients, as Jim has said, about it being a vicious cycle. And it corresponds with their menstrual cycle, but with the heavy bleeding especially, and the pain and discomfort, when they become anemic, it might not be to the level where they need a blood transfusion, even though sometimes it is, and then it becomes medically necessary, but it stops them from eating right, it stops them from exercising correctly. We're both vascular specialists. Everybody should exercise 30 minutes of cardiovascular exercise a day. It causes depression, it causes changes in your mood, and until you do something and actually break that cycle, you don't get better. And as Jim said, it comes on slowly, so you don't really recognize that there's a distinct problem, and if you take that problem out, you could correct that whole vicious cycle that's been going on and changing your quality of life.
Yeah, and that's good news for sure. Now, one thing again, if you're mentioning this kind of might develop gradually or kind of continue that way, so is there any reason to think if when you once do reach menopause that fibroid symptoms can either dissipate, kind of go away on their own? Will these fibroids shrink? What happens?
So the fibroids generally, once the hormones change with menopause, fibroids generally tend to retract and regress in size, and symptoms at that point will diminish significantly. Now, some women still have symptoms after menopause because they take hormonal replacement, but for the most part, our goal in treatment, if the fibroids aren't being removed, is just to get the women, it's a bridge to menopause, because once a woman reaches menopause, those symptoms basically go away.
Okay.
And we talked earlier about the perimenopausal surge, and sometimes in some women, especially as Jim has said, with the hormonal replacement therapy, you stay. It's estrogen actually that is stimulating these fibroids. And then there's also a small subset of women, there's substances actually in fat cells that stimulate the effects of estrogen. So we tell patients if they come to our office in their perimenopausal, we say let's try and wait. Let's see if we could do watchful waiting and get you through this. But then you do see some patients over time, a couple years later, and their symptoms haven't gone away. We get an MRI, they're still active fibroids, and they do need treatment. And so while almost all the time they do go away, there is a small subset of women who still do better once they're treated, even postmenopausally.
Okay. Now, interesting, we did point out, sometimes you mentioned, sometimes women don't have symptoms. They may not realize this. They might not present that they have the fibroids until it's seen that they have anemia. So I guess what I'm curious is, how are fibroids typically diagnosed, though, in women? How do you even find out that this might be what they're suffering from?
So most women find this out on their GYN exam, and oftentimes it's an ultrasound in the office performed by the gynecologist or in some imaging exam. But there are lots of women who are told they have fibroids and they have no symptoms, and those fibroids just stay there. They may even grow, but they can live with those fibroids. So it's a combination of finding this on exam, when a gynecologist does a good manual exam, and when they use ultrasound, in combination with the symptoms that lead to the diagnosis.
Well, and it's very important that just because you have fibroids doesn't mean you need to be treated. The vast majority of fibroids are actually asymptomatic. And in that case, what we do is we follow the patient. You follow the patient with physical exam and ultrasounds at time intervals, because, you know, unfortunately some women come in and say, you know, I have fibroids, I was told I needed a hysterectomy. And generally you don't need anything unless it's one of those cases with severe anemia requiring transfusions. We do only treat the symptomatic fibroids. Just because you have fibroids doesn't mean you need something done.
Okay, well, that's good to know. Well, now that we've identified what they are and maybe how they're diagnosed, when we come back, we're going to learn actually how they are treated. We're going to go more in depth on that, so you want to stay tuned. And in the meantime, you can always visit our website, allhealthallthetime.com, and submit your questions for all the doctors and find out more about the Health Channel on South Florida PBS. We'll be right back.
Wonder if you should get tested for colorectal cancer?
Is it really that common?
It is. It's the second leading cancer killer in the U.S.
I don't have symptoms.
It doesn't always cause symptoms, especially early on. And screening helps prevent the disease.
Oh? How?
By finding precancerous polyps so they can be removed.
But that test.
There's more than one screening test. If you're 50 or older, talk to your doctor about which one is right for you. Colorectal cancer screening really does save lives.
Many websites selling medication may look professional and legitimate, but the vast majority of sites selling prescription drugs are doing so illegally. Criminals use websites to sell counterfeit medications that may contain life-threatening toxins. Dot Pharmacy is a website verification program that helps you identify safe and trustworthy online pharmacies. Purchasing medicine online can be safe and easy. Just look for pharmacy to the right of the dot in website addresses.
Don't allow your weight to threaten your health or control your future. Excess weight or obesity can cause emotional and physical health risks. But you can take control. The Your Weight Matters campaign offers free resources and tips to help you measure and understand your weight. Take the Your Weight Matters Challenge. The free toolkit prepares you to speak with a healthcare provider about your weight. Your weight does matter. Take the challenge and take control today.
You're gonna love your new birthday present. Are you ready?
Ta-da!
Today, grown-ups will try anything to get kids more active outdoors. Good thing, since active kids have a better chance of building stronger bones and maintaining a healthy body weight. Here's an idea.
Let's go.
Get out there with them. A message from the American Academy of Orthopedic Surgeons and the Pediatric Orthopedic Society of North America, who remind you, for strong bones, activity runs in the family.
It's a teeter-totter.
Welcome back to the Health Channel, all health all the time. I'm Laura DeAngelis, and I am here with Baptist Health South Florida interventional radiologist Dr. James Beninati and Dr. Adam Geronimus, and we are talking about treatments for uterine fibroids. Doctors, again, it's great to have you both with us. We've kind of talked again about what uterine fibroids are, and now we want to move on. I'm a patient, I've been diagnosed with fibroids. What happens next?
So I think once you've been diagnosed with fibroids, the most important thing is determine the level, how severe your symptoms are. And remember, what we're treating here has to do with a woman's quality of life. So not everybody who has heavy bleeding, not everyone with anemia, not everyone with heavy urinating symptoms needs to be treated the same way. So when a woman is at a point where she feels that it's time to do something, time to get involved, then there are a number of different treatment options that can be offered, some invasive and some non-invasive. So Adam, why don't you start us off on some of those?
Well, thank you, Jim. So a lot of the patients, as Jim said, you get treated when you really decide, unless you're one of those patients who it becomes medically necessary. And we always start off with the least invasive, and that can include oral contraceptives, anti-inflammatories, iron supplements for patients who are borderline anemic, not needing transfusions.
Sure.
Hormonal therapy may be used to shrink the fibroids, hormones such as Lupron, which is really long-acting. We really don't love that because it sort of hides the problem, and when you stop it, it gets worse.
Okay.
There's also an IUD, an intrauterine device, which has been used as a contraceptive, but it's progesterone implanted, which causes thinning of the endometrium. And so this is a implantable device that lasts 3 to 5 years that can really help out in the right patient. The really interesting thing about fibroids is based upon the patient, their symptoms, and their anatomy, not one treatment is best for any specific patient. So it really, and that's where we're really special at treating this, is we look at the patient as a whole and really individualize the potential options in the treatment courses that they can then choose which they would like to do.
Sure, that makes sense. Now I do see again, one of the treatments on the list is the use of NSAIDs, and again, it seems like, is that basically though just used to help with the pain associated with cramping, more of kind of a pain management with the symptoms?
So that's a great question, and we use these non-steroidal anti-inflammatories for a lot of things in medicine. I'm sure many of you have taken them for pain, not just for menstrual cramps, but headaches. So it clearly helps with pain, but in fact, it also helps diminish bleeding, and which is a little unusual because many of you may have been told, don't take these drugs if you're taking aspirin and other blood thinners because it can increase your rate of bleeding. But with menstrual bleeding, it can help cause vasoconstriction and actually decrease bleeding. So it's used for two purposes. One is pain, and one is to stop bleeding, both.
Okay, well that is interesting. I did not know that, so I definitely learned something on that end today. All right, so now, doctors, let's say we've tried all of the non-surgical treatments. We've kind of tried one or two of the options that were on that list, and unfortunately I am still suffering. So is now the time that I start talking with my doctor about surgery and moving on to different procedures?
Yes, it is a time to do that, especially if the symptoms are bothering you, and like we talked about, that vicious cycle. You really want to meet with a doctor that talks about the correct treatments and gives you all the options. We see a lot of patients because we're specialists in second opinions, and they've been told we need this and are just given one option. We very rarely give patients just one option.
Sure.
And then whenever we see a patient, both Jim and myself, we always start off with the least invasive therapies, including doing nothing.
Right.
We move on to speak about uterine fibroid embolization, also known as uterine artery embolization. And then there's the other surgical options, starting off with the less invasive, such as endometrial ablation. You could do a hysteroscopic myomectomy depending on where the location of the fibroid is. And most of these treatment options, really, now we're talking about fibroids sort of like real estate. It's based upon the actual location, and we'll get into that with some of the models. You could have a laparoscopic or robotic, and robotic is just an advanced laparoscopic technique. It's not an actual robot doing the surgery. It's a gynecologic surgeon controlling the surgery. And then you could have a traditional or open myomectomy or hysterectomy.
Okay, so let's again kind of go through these treatments a little bit more one by one. If you could explain what is the difference between a UFE or a UAE?
Those are basically identical terms. They're interchangeable.
Okay.
So we do treatments in the artery, so some people call it uterine artery embolization, but the goal here is to kill the fibroid. So they're really the exact same thing.
Okay.
Occasionally there is additional blood supply also to the fibroids, and it really gets into more of the advanced technique of the procedures where there's blood supply coming from the ovarian arteries. So you're not just always treating the uterine artery alone. You're treating actually the entire uterus, and sometimes the blood supply comes from other arteries and not just the uterine artery.
Okay, and again, with some of these options, we mentioned they are minimally invasive, and you do try to go to those hopefully first if it's possible. Is one of the reasons for that just so that a woman has a quicker recovery time, or isn't suffering so much on the back end?
Well, certain types of fibroids and certain problems require more invasive surgery. But for the most part, we always try to go minimally invasive first. And there are a number of minimally invasive options on here, including the fibroid embolization. So there's usually generally a quicker recovery time and less complications with the less invasive procedures.
Okay, that makes sense. Now, one of the items on that list too was something called an endometrial ablation. So can you explain what that procedure involves?
An endometrial ablation is a procedure done by a gynecologic surgeon where they go in, and it's minimally invasive, done as an outpatient procedure. They go in through the vagina up into the uterus without making any incision, and it's ironing or heating of the endometrial lining. It does help with bleeding in a lot of cases. It does prevent any future pregnancy, unfortunately, because you're ablating or heating the entire lining. Sometimes, though, again, it depends on the location of the fibroids. A lot of the uteruses with a lot of fibroids become distorted, so it's not a smooth surface. So a lot of times, unfortunately, it's not the best treatment or the optimal treatment to get rid of the symptoms, especially a heavy bleeding. It also doesn't do anything about the bulk symptoms that we talked about. So really, it's a procedure that fits a very small subset of women with fibroids.
Okay, continuing also, let's talk about something I had not heard of before, a myomectomy. What are the benefits and drawbacks for that procedure?
So a myomectomy is an invasive procedure. It can be done laparoscopically or robotically, or it can be done with an open procedure. But that's basically leaving the uterus in place, but taking out the fibroid. And that sounds great, but there are some issues with that because it can be hard to get the entire fibroid out. So if you imagine in your garden, you pulled a weed out of your garden, if you don't pull the root out, that fibroid can come back. So one of the drawbacks to myomectomy is that the fibroids can recur. It's a great procedure in certain women with certain indications. It's used a lot for women who want to have future fertility. It doesn't work well when you have many fibroids. Usually it's best reserved for women with 1 or 2 fibroids.
Okay, now something else that I believe would be considered invasive is hysterectomy. For decades you kind of heard this as the gold standard for treatment for women with fibroids, but while it might have helped the symptoms, it also opened a Pandora's box for some women of sexual, hormonal, and emotional health concerns. So I guess let's talk about hysterectomy and kind of what the recovery time looks like for that, and why a woman, though, may need to resort to this kind of a treatment.
Hysterectomy is usually the last option that we talk about with patients, especially when we see them in conjunction with the gynecologic surgeon, because it's the most invasive and it requires the longest recovery time. And with the bigger procedure is, even though there's a low complication rate, it's still higher than the less invasive surgeries. It's really reserved for, of course, women who don't want any future fertility. And it's a procedure that a lot of women come in saying, I don't want a hysterectomy, I don't want an organ removed. Now, some of them are a little bit confused because they think that puts them in the menopause. They're not removing the ovaries. Even after menopause, the ovaries continue to secrete a very low level of hormones that is cardioprotective. So unless there's a strong history of ovarian cancer in the family, they leave the ovaries behind. But it's still a more invasive procedure, and now there's a lot especially with uterine fibroid embolization and the other less invasive procedures. We've followed our results. This was studied very thoroughly through the fibroid registry, through the Emmy study, about the long-standing results, and there's a lot of other ways to treat uterine fibroids and not have such a big surgery.
Okay.
And with all that said, I think we should point out that hysterectomy is actually one of the commonest surgeries performed in the United States. So while we recognize that there are many options, and we'll get into this in a little bit, we still think that far too many hysterectomies are being done for fibroids. And what we're really here about today is providing women with choices and options so that they can decide and that they have less invasive options.
All right, very interesting fact. Yes, 600,000 hysterectomies, I understand, are actually performed in the U.S., so that is a lot. So when we come back, we're actually going to hear a little bit more, too, about the options you started describing. So thank you for that, Doctor. So don't go away. You're going to want to stick around and hear more on that end. And, of course, you can always check out the website, allhealthallthetime.com, and submit your questions and find out all about the programming here on South Florida PBS. We will be right back.
Like millions of Americans, Emma was living with high blood pressure and didn't know it. There were no early warning signs or symptoms. But Emma's heart was working overtime, putting her at risk for heart disease and stroke. Following a physical, Emma was diagnosed with high blood pressure, also called hypertension.
People of all backgrounds can develop high blood pressure. Treatments differ based on risk factors including age and family history. But hypertension can often be controlled with healthy habits and medication when necessary. Eating more fruits and vegetables, following a low-salt diet, exercising regularly, and quitting smoking are often the first lines of defense to control high blood pressure. Your doctor may prescribe one or more medications to help lower your blood pressure to normal. Some rid the body of extra sodium and water. Others reduce the heart rate or relax the blood vessels. Always take medications exactly as prescribed and don't skip doses. While medications can effectively lower blood pressure when taken correctly, each type has potential side effects for some people. You might feel tired or have trouble sleeping. You may experience a dry cough, stuffy nose, leg cramps, frequent urination, or headaches. If you have side effects that don't go away with time, don't just quit taking your medication. Talk with your doctor and pharmacist, as there may be other medications or different doses that can control your blood pressure and have fewer or no side effects. Focus on the benefits. Taking your medication regularly will lower high blood pressure and protect your brain, heart, and kidneys from life-threatening consequences like stroke or heart attack, often the first scary signs of hypertension when left untreated. Control your blood pressure and reduce your risk by knowing your goal numbers
and monitoring your blood pressure at home or at your local pharmacy in between doctor's visits.
How's Franny?
She just graduated from obedience school.
Pharmacists play a key role in working with your physician to improve blood pressure management. We can address medication concerns and challenges. So talk to us about your treatments and goals outlined by your doctor. If taking your medication feels like a chore, don't just stop taking it. We can counsel you on working through side effects or determine when you need to see your doctor about possible changes in your medications. And we'll share healthy lifestyle tips to keep you on track. Whether you monitor your blood pressure at home or in the pharmacy, we're here to discuss your numbers and provide guidance. Okay, Emma, you're all set. I'll see you back here soon.
Welcome back to the Health Channel, all health, all the time. I'm Laura DeAngelis, and this hour we have been talking about uterine fibroids and how to treatment, and we've been learning about all of that with Baptist Health South Florida's doctors James Beninati and Adam Geronimus. So again, doctors, we've been learning a lot. You're both interventional radiologists, and that means that you're doing procedures using radiological images to kind of help you along the way and navigate what you're doing. And we also know that you both also specialize in uterine fibroid embolizations and uterine artery embolizations. So we're going to learn a little bit more about those procedures as we move forward. So let's get down to the nuts and bolts of those. Let's say I've been diagnosed, and that is kind of the path that I've chosen to take. I know it's a minimally invasive route, but again, kind of walk me through the procedure. Am I checking into the hospital, first of all, to have this done, or is this something done on an outpatient basis?
So this can be done in a hospital as an outpatient, or it can be done in a freestanding outpatient facility. I think the important thing is that because it's minimally invasive, you either go home later the same day or the next morning. In our practice, actually, we often choose to keep people overnight, just because for a lot of moms and a lot of people that have a stressful life, it's a nice break when they have pain and they're uncomfortable to just have the night here and not have to go back to a stressful situation. But the recovery's quick. Patients are usually out of bed within 4 hours after the procedure. And the procedure takes only about 30 to 40 minutes to perform. It's actually quite quick.
Wow, okay. And as far, you just mentioned it's kind of a short procedure, doesn't take a lot of time. And as far as anesthesia goes, are you kind of under general, or how does that work?
We do these procedures using moderate sedation, which is a combination usually of fentanyl and Versed, and it's the same as basically like a colonoscopy. Most of these women are sleeping or dozing off during the procedure, and frequently when we're finished, they say, have you started yet? And so the procedure itself is not very uncomfortable, and it doesn't take very long. The setup is in the preparation for the procedure can be sometimes the bulk of the time.
Okay. I'm just curious, the anesthesia you just described, is that something, you hear the word twilight sometimes that people have for minimally invasive procedures. Is that what we're talking about here?
Yeah, that's pretty much what it is. It's a gentle, it's a sedation, so you're not really, everybody reacts a little bit different to it. Some people are completely out and sleeping the entire time. Some people are just sort of in what we would consider a twilight.
Okay, all right, so that makes sense. All right, so I know that we have some show and tell to go on here today, and Dr. Beninati, I know that you've brought the equipment that would actually be used in the procedure, so why don't you kind of show us what you have and explain the line there and how it all works?
So this is very interesting. Most of what we do is minimally invasive, and so we're talking about working through little tiny needle punctures in your body. So we don't need stitches. When we're done, we don't need to close anything up. And we have this, I'm going to show you what the catheter is. This, and if you take this back end here, and we'll focus this on this white background here. And if you see how small that is, that's all that goes into your body.
If we could show the tip there.
Here.
There we go.
So let's see if I can get
move
that.
paper
Right, there
down
we
a
go.
little bit. There
And
you
you
go.
can see that we have a little wire that comes out of the skinny little catheter that we can steer in different directions.
Wow.
And using X-ray guidance, we can steer this to any blood vessel in the body. We can get this to the brain, we can get this down to the feet, and we certainly can come in and put this in all the blood vessels in the pelvis. So we go into the vessels that feed the uterus, and when we get that small catheter position there, we have these particles that we inject, and the particles come in this little syringe. The particles really, I think if I had to describe it to you best, they're like sand. And we put these in, and these get taken up by the fibroid, by the blood supply to the fibroid, and they kill the fibroid. And we kill all the fibroids. We don't just treat one, but we'll treat all the fibroids in the body. And sometimes we'll have to use several vials of this. So we could use anywhere from 1 to 5, 6, 7, 8 vials of these. They're inert. There's no complications from these particles, so people don't have allergic reactions. And that's really the procedure.
Okay, well, we've seen some of the props, if you will, that are used, or the tools. And Dr. Geronimides, I know you also, you brought some slides that kind of also help illustrate the procedure and what's happening. So kind of, I guess, let's start with the first one. From the slides that you brought. So tell me, what are we looking at here?
So what we're looking at here is an MRI, and we get MRIs pre-treatment in all the patients because, first of all, it tells us which patient is a candidate and which isn't.
Sure.
And this fibroid, this is looking at a patient in what we call a sagittal image, or from the side.
Okay.
And so to the left side of the screen, you see that would be the belly button, and then the right side is the back area, and that's the white thing is the uterus, and in the middle of the uterus you see a big white ball. That's actually the fibroid. It has that little black area in the center, and that shows us that the fibroid is taking up the dye that it has been injected for the MRI, and it lets you know that this fibroid is active and it's alive vascularly, and it can be treated by embolization. And so once we see this, and it also tells us the location, how we talked about which patient is a candidate for which type of procedure.
Sure.
So this would be a very good candidate for uterine fibroid or uterine artery embolization. So when we see this, then we have this way before the treatment, before the consultation, and we tell the patient their options. And this lets us go on to fibroid embolization, and it also gives us a basis for follow-up. And with the next slide, is actually images from a procedure. And if you see that has that black line going down, and this is what we're seeing, we're in the room, we're looking at these monitors as we're doing the procedure, is the catheter that Jim was showing. And that catheter is in what we call the hypogastric or internal iliac artery, and then there's a smaller catheter going through it all the way down into the uterine artery. So we get past any branches down to what we call the lower uterine segment or vagina, so there's no what we call non-target embolization. These particles only go where we want them to go. And once we're there, we inject the small particles. And the fibroids are bloodsuckers, and as Jim said, they take up these particles, and we get even the fibroids that you don't see. So basically you're starting all over, because women under the age of 40 have a chance of not the fibroids coming back, but of developing new fibroids, but they take time to grow. So we get even ones that you really can't see.
Okay. And we do see, Doctor, I just want to ask you, we see the catheter in there, as you mentioned, that we saw also before, and I know you explained to my producer that used to be that you would go in through the femoral artery to get that line in, but now you actually use the artery in the wrist. I'm just kind of curious about why that switch happened, or what makes for that change.
We do them both. It's the same procedure no matter how you do it. It's the same, the catheter winds up in the same location.
Okay.
But the wrist is a little bit of a different recovery in the immediate post-procedural time. A lot of times we know the uterus likes to cramp. It does with the menstrual cycle. This procedure, we're changing the blood supply. There's some cramping and discomfort. And if we go in through the wrist after the procedure immediately, you could sit up, you could lie on your side, and you don't have to lie with your legs straight. Also, sometimes it can shorten the procedure time because you're going straight down towards the uterine artery. Either way, the end result of the procedure is the same.
Okay, and that being said, I believe we actually have a side-by-side image of pre-treatment and post-treatment. So to me, again, layman's eye here, it looks like a huge difference. So again, if you could just kind of tell us what we're looking at and what happened to that tissue.
So if you look at the picture that Adam showed you earlier on the left, you see this big white ball inside of this big white uterus. And now you look on the right, and first of all, you see this large black area. That's the fibroid that's now dead. When it was alive, it had blood supply, and that's why it's white on the left. Now, not only is it dead, you notice it has shrunk in size.
Yeah.
And most importantly, you notice the entire uterus, the entire white area, has also decreased in size. So we've decreased the size of the uterus and the size of the fibroid. This is a successful embolization.
Right.
And also, this MRI was done at a 3-month interval, so only 3 months after the procedure. And we know that that's going to continue. It becomes basically scar tissue. It's going to continue to dehydrate and shrink over time. So we wouldn't do it for any reason. But if the patient had, say, pain or symptoms 2 years down the road, we could get a follow-up MRI, and we would actually see that that's even significantly smaller.
And you know, that actually brings me to another question. So again, you could see in those images the difference, and you mentioned, of course, you know, kind of bloating is one of the symptoms people suffer, and you can see why that was relieved based on that procedure. But you mentioned a couple of years down the road. So once you've had this procedure, is it a guarantee you'll never get fibroids again? Can they reoccur? What can women expect?
Yeah, it's not guaranteed that you won't get them again. Many women never have another problem. But some women can get fibroids again, and sometimes those fibroids actually receive blood supply from the ovaries, not just from the uterus. So they have second sources of blood supply. So in a small percentage of women, less than 10%, there can be a recurrence. And in those women, the procedure can be done again. Because it's so non-invasive, repeating the procedure in a very small percentage of women isn't a problem. And the one other really very quick point is that the fibroids, the ones that we treat, don't go away. We're not cutting them out, so we're not doing a surgery. They shrink, as you saw in the picture, and they become like scar tissue. They stay there. But women shouldn't be alarmed when they have ultrasounds later on and their gynecologist says, hey, you still have some fibroids. If their symptoms are gone, they're treated, and that's perfect.
Okay, and I think that's important to know. And like you said, obviously important to keep following up with your doctor and just get your regular exams and make sure everything is okay, right? Okay,
exactly.
So that's great. All right, well, on that end, doctor, don't go away because we still have more coming up. And in fact, we just saw what the procedure looked like, but we're actually going to meet a patient and hear how uterine fibroid embolization was a game changer for her. And please be sure to visit our website anytime, allhealthallthetime.com. You can submit your questions for all the doctors and find out more about the Health Channel. We'll be right back.
Every year, millions of Americans are exposed to a contagious virus.
What is this virus? It's stigma.
Stigma promotes an environment of shame,
fear, and silence,
which prevents millions of people from seeking help.
But there's good news.
The National Alliance on Mental Illness believes stigma towards mental illness is 100% curable.
So do yourself and everyone a favor.
Go to curestigma.org and get tested for stigma.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Hi, I'm Janelle Hale, founder and CEO of the National Breast Cancer Foundation. No one should face breast cancer alone. When I was diagnosed 36 years ago, there was no internet, and I had to make a decision with little information. Early detection saved my life. It could save yours too. To learn what every woman needs to know about breast cancer, visit nbcf.org/hope.
At Miami Cardiac and Vascular Institute, we're celebrating our 30th anniversary. 30 years of pioneering minimally invasive techniques. 30 years of hard work and dedication by our top-tier leadership and world-renowned physicians and clinical staff. Creating a world-class comprehensive heart and vascular care center unlike any other. Committed to our guiding principles of outstanding quality care, continuous innovation, and a drive to save lives. 3 decades of excellence are the foundation for our exciting new expansion. A state-of-the-art facility, a first-in-the-world environment, with the latest technology. Recognized as one of America's best hospitals. We're proud of our history and committed to providing the best care today and in the future. We are innovators. We are leaders. We are Miami Cardiac and Vascular Institute at Baptist Health, South Florida.
Hello, everyone. You're watching the Health Channel. I'm Laura DeAngelis, and we are winding down this hour's discussion on uterine fibroids with Doctors Beninati and Geronimus, interventional radiologists with Baptist Hospital, South Florida. And doctors, now we're going to hear from a couple of patients, and we actually have a quick hello from one of Dr. Beninati's patients. So let's meet Margaret Malone.
I would love to tell Dr. Beninati that he is an awesome doctor, and that I would love for him to continue doing what he does, because there's a lot of women that have this problem and do not realize there is an alternative to hysterectomies.
Oh, well, Dr. Beninati, I'm sure you're happy to see that Margaret's doing well.
Yes, we are. Yeah.
So, all right, great to know. Well, we actually have another patient. We have a special guest, and she's actually joining us on the line. We have Brenda Walker, who is one of Dr. Geronimus' patients. And Brenda, hello, are you there?
Good morning, I am.
Oh, yes, there you are. Fantastic.
Good morning, Brenda.
Good morning, Dr. G. How are you, sir?
Good, good.
So Brenda, Dr. G told us that you were a textbook case of uterine fibroids. So tell us, when your fibroids were at their worst, what was a typical day like for you?
A typical day, I would say, would be bloating, lower back pain, cramping, and extremely heavy cycles. Extremely heavy cycles.
That sounds very uncomfortable. Now, what about your pain level, Brenda? I mean, was that pretty severe?
It was extremely severe, to the point sometimes it was debilitating. Just an overall inability to function and have just a decent quality of life.
Okay, and that's definitely not a good thing. Now, I'm also curious, Brenda, did fibroids run in your family?
No, ma'am, not that I'm aware of.
Okay, so unfortunately for you, I guess you were the first. So
I'm the only girl of 6.
Oh, okay. Well, there you go. All right, so you were the first. Now, Brenda, I'm curious too. How long has it been since you had your procedure, and what's your recovery been like?
I want to say that it's been about 4 years now, going on 4 or 5 years now, and the recovery has been absolutely amazing. And when I tell you it has been night and day, it has literally been night and day. And my biggest claim to fame on that is I wear white now anytime I want to. I have literally been able to reclaim my life.
Oh, that is wonderful, wonderful news, and we love hearing a good news story. And doctors, I'm just curious: is Brenda's outcome kind of typical of what you're hearing, or what do you have to say about how she's doing?
Yeah, this is what we expect. I mean, Jim and I, we follow our patients so closely, and especially in patients like Brenda with heavy menstrual bleeding, we're between 97 and 98% successful in bringing the menstrual cycle to the point where the patient themselves considers the procedure a complete success. And it's patients like Brenda are the reason why the two of us really love doing this procedure. We want to give these patients back their life with the least amount of recovery. And I remember, Brenda, you had the procedure right before you were getting married, right?
I surely did. Getting ready to celebrate an anniversary at the end of this month.
Congratulations.
Well, thank you.
Brenda, this is Dr. Beninati. We haven't met, but first of all, thank you for being with us. And
my pleasure.
Your story is so heartwarming to all of us, and it's actually very typical of many women that we treat. And I really enjoyed listening to you say that your entire quality of life, the way you function, the way you feel about yourself, has improved. And that's been stable now for 4 years. Is that correct? It's been really
correct.
Durable.
Wow.
That is correct. 100%. When I say that it has been a life-changing procedure, it was a life-changing procedure because prior to this I had a myomectomy, only for the fibroids to return. And this provided me with a procedure that was less invasive than a hysterectomy and barring the failure I feel of the myomectomy, it just gave me the best of both worlds, less invasive, but I was assured that the fibroids would no longer be an issue. And when the fibroids no longer became an issue, that's when I began to live. And it has been a game changer for me. The quality of life, just the ability to enjoy life has been restored.
Well, that's wonderful news, Brenda. And you just mentioned another procedure that you did try first. The doctors, we actually talked about that before. So can you just remind our viewers what is a myomectomy, which Brenda went through before, having success with this other procedure?
So a myomectomy is a procedure where the uterus is left in place, but the fibroid is cut out. And one of the problems that we mentioned before is that that's like pulling a weed in the garden where you pull it out, but the roots are left under the soil, so the fibroid can come back. And that's Brenda's description is actually quite a common thing that we hear from women.
No, that's really good news to hear that Brenda is doing well. And Brenda, I understand, when we invited you to join us on the show today, you had just been telling a friend, I guess that very same day, about this procedure. And it does sound like you're, spending time just kind of getting the word out there and trying to share what the procedure has done for you. As you said, it has really been a game changer.
Absolutely, because one of the things, and I'm sure it's probably been mentioned earlier in the show, it is something that is very common among African American women. And I have a very dear friend who I will be vacationing with later this month who is experiencing what I experienced prior to the surgery with Dr. G. And one of the things that I was saying to her, because she's in the same position, she's to a point that there are days that she literally cannot function due to the pain and due to the heaviness of the cycle. And I was sharing to her that if she wants to live a more successful life. She's a educator. I said she needs to have the surgery. I literally was just talking about Dr. G when I received the call, because I cannot stress enough, especially to African American women, that life can be better than what we know it if we would simply take care of this issue.
Brenda, I think I remember correctly that you found us on your own. You weren't referred by a physician. Were you ever told about uterine fibroid embolization by any of the physicians who have treated you previously?
I had never heard of the procedure. I found Dr. Geronimus through a church health fair. The church that I belong to invited him and his staff. They came, and what they were talking and the freedom that they offered was right up my alley. And I think they showed up in April at our health fair, and I think in May I started consulting with Dr. Geronimus, and it wasn't too long after that we had the procedure done.
So Brenda, that's a wonderful story, and we need people like you to help spread the word. We have a lot of published data on fibroid embolization that shows it's every bit as effective as hysterectomy and myomectomy, and that the outcomes are great. But unfortunately, the reality is it's not offered to everyone. And this is a very big problem. So through people like Brenda, we get lots of our referrals, and we really appreciate that help. And for all the women listening, I think it's important that you know that you do have choices, and you can seek out help from an interventional radiologist, and that fibroid embolization is not experimental. It's a proven procedure with lots of very good data to support it.
Absolutely. And Brenda, just kind of to reiterate what the doctor said here, I mean, you're obviously, you're speaking with us, you're trying to let our viewers and listeners know about your success story. But again, what would you say to other women who maybe like you were 4 years ago prior to meeting Dr. Geronimus, were suffering about getting out there, learning about the options, and knowing that this is something that can get better. You don't have to be locked in your house when you're suffering with these symptoms. So again, Brenda, just a word of encouragement.
I would encourage anyone that is experiencing or that has experience with these fibroids, if you want to live a better quality of life, if you want to be free to roam about the country and live, seriously give consideration to uterine fibroid embolization. It is a game-changing, life-changing event that you will not regret.
Wow. Okay. Well, Brenda,
thank you very much for those kind words. We really, really, really appreciate it. And I think by you speaking, you're doing a tremendous service to all the women out there who are suffering like you used to.
Yeah.
Thank you
Wow.
so much.
Wow, that was a powerful story. Actually, we definitely thank Brenda for sharing her story and letting us know that there are options out there. And I think, doctors, again, just to wrap things up again, that takeaway message, just what to leave our viewers with. I think Brenda summed it up for us, but again, you know, what you just like people to know who might be suffering from this condition.
Brenda was fantastic. And the take-home point is that women, you have a choice. There are lots of options. And you need to seek out that choice. Interventional radiologists can perform this procedure. Here in Baptist Health at several facilities, we can offer this procedure. And if we don't think this is the best thing for you, we're going to tell you that. But if you are a candidate for this, it's something that I think can be, as Brenda pointed out, a game changer in your life.
Yes, and remember, it's your body and your decision, and you have options. It's not a situation with uterine fibroids where generally you need anything, with the exception of a very few cases of severe anemia requiring blood transfusions. Do you need anything immediately? And there's information out there, and get that information and help yourself make the correct decision for you.
Well, absolutely. And doctors, a lot of great information you shared with us this hour. Thank you so much for your time today. And again, another shout out and thank you to Brenda Walker for joining us. And we want to thank you for joining us and watching us on this hour. And we hope you'll stick around for what's coming up next on the Health Channel. And don't forget to check out our website, allhealthallthetime.com, anytime you feel like it. I'm Laura DeAngelis, and I'll see you next time.